Okay, we're here at the AATS Mitral Conclave 2015. We're actually in a break right now, but a lot of energy this morning, and you can hear them trying to call people back into the meeting. But this is a unique opportunity for me to visit with two of the world's experts in rheumatic heart disease. Thrilled to be joined by Dr. Taweesak from Thailand. I know you've had extensive experience, and Dr. Manuel Antunes from Portugal. Manuel, tremendous experience in South Africa and Mozambique and all that. You know, it's interesting. When I was in medical school, we actually saw rheumatic heart disease in the United States. Now we don't see much. So what's the burden of rheumatic heart disease in the world? What your experience?
Well, in all the southern hemisphere, and that is South America, Southern Africa, and Southeast Asia, it's still a major health problem, and a lot of children get rheumatic disease every year, and then they have several bounds. So there are millions and millions of people who actually would benefit from surgery.
So in your experience, it's stable or increasing? It's not decreasing in number?
Well, probably it is decreasing still. When I speak to my friends in Brazil, especially in the urban centers, they say that there is clearly a decrease in the number of patients that come now with rheumatic heart disease. Because the bouts that they have of rheumatic fever are cured on time before they affect the heart valves. Right. So it probably, at least in the more developing regions, it probably is decreasing. I don't know what it is in Thailand.
What about in Southeast Asia in your experience?
I think valvular heart disease is still a big problem in this part. But that may be some change a little bit. I mean, in big city, in well-educated group, there may be decrease in rheumatic.
Decrease.
Yeah, decrease. But overall, it's still the big problem for the whole region.
In the entire Pacific Rim? I mean, you see it throughout the Pacific Rim?
Yeah, I have been through in South Asia, in China, in India. It's still the big problem, especially rheumatic heart disease.
You know, in this country, when we see rheumatic disease, it's usually somebody who's, you know, had the initial insult years ago, and the valves look very calcified, thick, and retracted. Is the disease that you see in Africa and South America or in the Pacific Rim a different disease? In other words, is it less scarring, or is it?
In my country, it's exactly what you say about the United States. We are ever still a straight relationship with ex-Portuguese colonies in Africa. So we receive a lot of immigrants, and some of those do have new onset rheumatic heart disease at young age. But we still, all the people who had rheumatic disease, rheumatic fever 40 years ago, 4 or 5 decades ago, they're now 50, 60s, and we have to treat them. Those valves are different. Yeah. Many are calcified, and we are unable to replace them, which doesn't constitute a major problem, because in these type of populations, to put in a mitral valve prosthesis is not a major problem. But we still work on the premises that we can preserve the majority of these valves. Indeed, we have been able to preserve about 75 to 80% of these valves. And they are easier to repair, and they are more durable in their repairs, because the histologic process of the rheumatic disease is stable now. It is not evolving. That's completely different to what happens in these young populations in Africa and Asia, where the histologic process is still evolving. So you can have a perfect repair, but the progression of the disease is going to destroy it.
So do you see a different disease? It was my understanding. I mean, not a different disease, but a different pathology of the valve in Bangkok. I mean, in Thailand and in Asia.
Yeah, that's a very interesting question. Recently, I traveled quite a lot to several countries, and although the disease is rheumatic in the same pattern, I mean, inflammation, thickening, but there's some various degree of difference. The calcification, the thickness, the toughness of the tissue from country to country. There's some difference. They're very interesting. We should learn something from that.
That's it.
Yeah.
So what important is, when you read the literature, you have to clearly separate the reports that come, for example, from Japan, a lot coming there, where the mean age of the patients is 50 years. from reports coming from Southeast Asia, from South America, from Southern Africa, where the mean age of the patients is around the 20 or 25 years. These are two specifically different types of disease from the surgical point of view, of course.
Okay, so that leads me to my next question. When would you replace and when would you repair? Don't tell me how you'd repair. I'm going to ask you that in a minute. But so when do you replace a valve and when do you repair a valve?
That is the question that I'm going to answer later on in this conclave. And of course, you have a dilemma here. I already told you, if it is in Portugal in a 65-year-old patient who has a more difficult valve, you're not sure that it's going to last. I don't feel really very guilty in replacing the valve.
Absolutely.
But if you find that I'm not talking about 25-year-old in South Africa or in Mozambique, I'm talking often in 6-year-old patient with rheumatic disease, where you know that whatever repair you do will not last that long, but you can't replace it with a prosthesis either. Bioprosthesis will fail very quickly and they do not take care of the anticoagulation. So in those cases, sometimes you feel that you're just buying time.
So you're really looking at not only the disease, what the valve looks like, but what the patient looks like and their longevity. You're looking for the most durable approach to that. Is that correct?
Well, not really, because you know that the repair is not going to be the most durable approach, but in any case is the best approach for that particular patient, for that particular population, which not only has to do with the age, but also with the education, because not every child in Mozambique has the same level of education. Some have a very low economical condition, which makes it impossible for them to adhere to anticoagulation, to other forms of therapy.
I know I've heard you talk many times about this question: when do you repair, when do you replace? And obviously, and what Manuel.
May I say that he is an expert of making repairs that are impossible to repair.
I've seen. I agree. I've seen it, but so the question comes up, and I think what Manuel was alluding to is this thing about follow-up of the patient, anticoagulation, and durability. When do you repair, and when? I know you're an expert, and when do you replace?
Yeah, I think that's one of the very questions, because there are several factors being involved: the patient factor, surgeon factor, socio-economic factor. So I think we just try to find the better way, like in South Asia and Thailand, to replace the valve in female live in rural area. Although they offer the immediate good result, but there's some problem. So we try to repair, and then try to repair with the techniques that we learned from the pioneer life. Professor Antunes is a pioneer in this, and then try to develop something that at least can postpone or improve the quality of life of something like the young lady who would like to have baby. They can have baby and then they come back later. But overall, through the year, we know that we have the better technique because we understand the disease more. And the other thing is that for whatever reason, if the repair fails, the patient have time to come back instead of mechanical valve that is
mortality is really involved repair.
Yeah, that is the key that we try to do.
Exactly right. Exactly right. A failed prosthetic valve can be catastrophic.
And quick and develop
quickly. Yeah.
And the good news is that with this kind of the approach, we slowly move toward more complex, like mixed lesion MS, MR, or predominant MS. We can repair more and more with at least right now very gratifying midterm result and continuing.
That's amazing. Yeah. So I know it's a difficult question. How do you repair? So what are you doing when you want to do a typical repair?
Have you already heard in that first session of this morning's conclave? There are 5 ways to do it for every single lesion. Right. I still adhere to the basic concepts of Carpentier. And I was just saying in the interval to someone that in my perspective, the major improvement that we made after those initial concepts of Carpentier from 30 years ago was the introduction of the cordal, the artificial cordal. those were major, that made a major impact, not only in the degenerative disease where it was created for, but also in the rheumatic disease, which is amazing because you operate on 6-year-old or 10-year-old children, and you would think that you put in an artificial chorda with a certain length for that body size, and that when the child grew, it would be insufficient. It does appear as if it grew, the artificial chordae with the patient, probably because it is compensated by the papillary muscle. So we have seen a sudden jump in the long-term results for the better when we use the artificial chordae.
And then, of course, as you gain experience, each one of us is
created our own tricks for dealing, minor tricks. They're not really new techniques, but just minor tricks to deal with specific problems in the valve.
Yeah, I mean, obviously it's a difficult question because every valve looks different, but I'll come back to that in a second. But you've shown us techniques where you're actually almost taking off layers of the inflammatory changes.
Yes.
Is that correct?
Yes. I think by starting to repair the valve based on what we learned from our pioneer, now we know something that we have to put more emphasis, that is the rheumatic process does impair the diastolic function as well. I mean the valve open not as good as normal. Correct. So we have to correct all of this restriction, fusion, shorten of the cord more. And also the pliability of the leaflet is the key. That we find a plan to peel it out and make the leaflet more mobile. In that way, we can improve the diastole as well as systole. And by the use of autologous pericardium and neochordal reimplantation, we can recreate the damaged tissue like a leaflet and the cord. And that does improve the successful rate.
Regardless of the age of the patient? In other words, if you have a patient who had this 40 years ago versus 10 years ago, I'm just curious because I've looked at these valves by echo all my life, and I'm just thinking, you got this.
The big question is really whether
This inflammatory process just does not regrow. But as he said, what important is here, if you gain a couple more years, a few more years in that particular population, that's absolutely fundamental. It may not be as useful in the older patient, in the 65-year-old patient that I do, to decalcify, to make it thin, then you risk to have to come back at the age of 80. But it's also important to say, when we spoke about repair versus replacement, that a reoperation after repair, it's almost like the first operation. In a reoperation, the major risk factor is removing a prosthesis, removing it from its place. You can remove mitral prosthesis and damage the aortic valve. While if you have a previous repair, basically it's the same as if it was a vision valve.
It's interesting. I'm learning so much just listening to you all, and I could talk all day, but we can't. But the concept that you both are emphasizing, the fundamental knowledge of not only the mitral valve apparatus, but the mitral valve repair operation is really critical. Final question: is there a preference to using, in the world today, we see people going away from mechanical prostheses with the hope, or maybe false hope, of valve-in-valve down the line, failed prostheses we can do. Does that influence your choice of prosthetic valve? I know if you had to put in a prosthetic valve, mechanical versus a tissue, what are your thoughts?
Yeah, this is another big concept about in the future, and then it does have some influence in terms of choice of the type of the prosthesis. That means we tend to use valve prosthesis in the more younger group now compared to the past. But whatever, to use is too young, the reaction is still there. That's why it's not so good. But the valve-in-valve, to me, I think trying to repair and then put in the valve prosthesis later and then put in the valve-in-valve is really viable, and then can make the patient avoid from the need of the anticoagulation as a whole process. That is true.
I agree with that. I was still am a mechanical valve man. I preferred it for a long time. In fact, until about a decade ago, I was happy to place a mechanical valve in an 85-year-old, aortic valve in an 85-year-old. If it appears that you would last for another 10 years or so. Now, with the valve-in-valve concept is the most important concept in this percutaneous implantation. I think it is a technology of the future, but it has been promoted far too fast. There have been the valves are now much better than they were 6 years ago, and they will be much better in 6 years. So maybe in 10 years this conversation would be completely different. But you cannot use that for a justification not to repair a 10, a 15 or 20-year-old, because the valve prosthesis, bioprosthesis you put there will last only, say, maximum 10 years. Then put a valve-in-valve would last another 10 years, and the child is still only 40 years old, is only halfway through his or her life. So that does not remove the concept, the need for repairing, going as far as you can with repairing, being safe, trying to calculate in your own experience how long those repairs last on average. But it is important to keep repairing. And we have learned that as your experience increases, that you can repair more and more valves, even valves that you could not repair.
Well, I mean, that's what's been so amazing for me to learn from both of you and watch that. I mean, because in this country, most people say, oh, we have to replace it, but you've done so. I want to compliment both of you because you've done so much to help so many patients around the world with rheumatic valve disease. I mean that sincerely, plus the fact that you're educating all of us. So thank you both for joining us. Thank you.